Hello and welcome to this lecture. Today we are going to discuss the laxatives. Why laxatives have been used? They have been used for the treatment of constipation. If we classify laxatives, it could be classified into following types such as bulk forming laxatives, for example, methyl cellulose, stool surfactant such as glycerine. And then we have osmotic laxatives. Then we have stimulant laxatives such as aloe, bisacodyl. Then we have chloride secretion activators, for example, lubiprostones. Then we have opioid receptors antagonist such as almeopan or methyl naltrexone. If we take a look at how we manage the constipation, especially chronic constipation, this is a series of steps that is actually going on. So first of all, we have to see the fecal impaction, which is the main sign and symptom. If patient having fecal impaction, yes, then we have to give them enemas, poultices, or manual disinfection, or bowel regimens to prevent the reoccurrence. If patient don't have the fecal impaction, then we need to see that if maybe that constipation is caused because of the medication. If it is caused because of the medication, then remove that medication. Increase the fluid intake, exercise, activities, or increase of the fiber diet. And then we need to train them, which is known as time toilet training. So through these ways, the constipation can be reduced if patient don't have fecal impaction. If patient having fecal impaction, then enemas, poultices can be given. And then after then we can see that if patient symptoms become better, if there is no fecal impaction now, then again we need to go back to see the lifestyle changes like increase of the fluid intake, increase of the activities. For example, if patient having fecal impaction, we give enemas, poultices. We give the drugs like milk of magnesia, lactulose, sorbitol, senna compounds, and bisacodyls initially, and see the patient whether it get improved, the constipation has been reduced or not, or effective in treatment. If the treatment is effective, then continue the treatment. If the treatment is still not effective, then we can give polyethylene glycol. After then, the given of the polyethylene glycol, we need to see that whether now patient have been improved, now the constipation has been reduced or not. If the treatment is effective, then continue the therapy. If the therapy is not effective, then we can give lubiprostones, and then we can give the almeopan or methyl naltrexone, which is opioid induced constipation, which is used in the treatment of opioid induced constipation. Let's discuss one by one what are these treatments. When we take a look of fiber laxatives, it is used for making the bulk formation, and if you see the name indicates fiber, so it means it helps to make the bulk of the stool. And these bulk forming laxatives are actually indigestible hydrophilic colloids that absorb water and form the bulk. Common preparations are plant products such as methyl cellulose. The second example is glycerine, and especially glycerine's poultices are very famous. They are used as soft surfactant agents or used as softeners, which help to soften the material. It can be given as orally or as can be given in the form of enemas. Then we have another stool softener, which is Docusate sodium, 250 milligram. which is also given in the form of enemas. Then we have another example of mineral oils, which is a clear viscous oil that lubricate the fecal material and help for reducing the fecal impaction in young children. But the long-term use can impair the absorption of fat-soluble vitamins such as A, D, E, K. Then we have osmotic laxatives such as magnesium hydroxide, also known as milk of magnesia. The recommended dose in adults is 10 to 20 ml once daily at bedtime. In children, it is recommended 5 to 10 ml once daily at bedtime, and they are used to prevent chronic constipations. And the functions of these osmotic laxatives are they are non-absorbable sugars or salt, and they help by metabolizing the colonic bacteria. These sugars are metabolized by colonic bacteria, producing severe flatulence and cramps. Then we have polyethylene glycols, which is used to relieve occasional constipations or softening the stool. Then the other examples are aloe vera. Then we have polyethylene glycol, which are commonly used for cleaning the gastrointestinal endoscopic procedures. And the solution is designed so that no significant intravascular fluid or electrolyte shift occur. Therefore, they are safe for all patients. For optimal bowel cleaning, 1 to 2 liter of solution should be ingested rapidly over 1 to 2 hours on the evening before the procedure begins, and again 4 to 6 hours before the procedure for treatment of prevention of chronic constipations. Small dose of polyethylene glycol powder may be mixed with water, juices. Then we have stimulant laxatives such as aloe vera, which is actually anthraquinone derivatives and obtained from the plants. These laxatives are poorly absorbed, and after hydrolysis in the colon produce the bowel movement in 6 to 12 hours when given orally, and within 2 hours when given rectally. Then we have bisacopodyl, which is used orally for bowel evacuation for constipation. And for bowel evacuation, initially they given 10 to 20 milligram the night before the procedure, followed by 10 milligram rectal supplement in the next morning. Then we have lubiprostone, which is chloride secretion activators, and they are used for chronic constipation and irritable bowel syndrome because with predominant constipation. It acts by stimulating type 2 chloride channel in the small intestine, and this increases the chloride rich fluid secretion into the intestine, which stimulate the intestinal motility and shorten the intestinal transit time. And over the 50% of the patient experience bowel movement within 24 hours after taking one dose. The dose recommended is 24 microgram orally twice a day for the treatment of chronic constipation, and having the same efficacy if someone need to use for long-term therapy. Then the other example is alvimiopan, which is opioid receptor antagonist, and they are used for acute and chronic therapy with opioids that may cause constipation and decrease the intestinal motility. So because of the use of the opioids, for example, for relieving the pain, we know that constipation are the side effect. So the use of the opioid antagonists such as methyl naltrexone is used for treating that constipation. Methyl naltrexone is approved for the treatment of opioid-induced constipation in patients receiving palliative care for advanced illness who had an inadequate response to other agents. So actually the opioid receptor antagonists are used under those conditions where the other therapies we discussed before is ineffective, and usually The drugs such as L-renopan and methyl naltrexone has been given when patient is under the treatment with opioid agonist, and it can be given as 12 milligram of capsule administered orally within 5 hours before the surgery and twice daily after surgery until the bowel function has been recovered, but not more than 7 days, because it having some cardiovascular toxicities. So thank you so much for today's lecture. Hope to see you again.